Good evening, everyone. I'm Dr. Sravani, working as a clinical head of the emergency department, Yashoda Hospital, Somajiguda. Invite you all for today's webinar session. We, Yashoda Hospital Emergency Department, every Friday come with few interesting topics. The main motto is to get the awareness among the participants. Yet today we have we have come with a good important topic by Dr. Naveen Nimmala sir, who is a Joint Secretary, SEMI, Telangana chapter, and he is a Group Head, Emergency and Academics at Sri Sri Holistic Hospitals, Hyderabad. Today we'll have a case-based discussion on few emergency topics. So I hope everyone is ready. Over to you, Naveen sir.
Uh, Actually, today's topic was supposed to be a different one by Dr. Ankur. Unfortunately, he couldn't join us, so there's a last minute change in the topic. Let's go through some of the case scenarios that recently presented at the ASEM. So the same presentation we'll be going through. So in this, we'll be asking some questions based on a case, and you can just post your answers in the chat box. So do we have the chat box or open for the audience? Just check once.
Yes, it's open.
Okay. So you have a 56-year-old, which brought by the friends from their workplace. As per the vitals, the patient looks stable, like heart rate is 187, BP 100/40, sugars are 57 milligrams per deciliter, the temperature is normal, saturation is at 96% on room air. So tachycardic, blood pressure looks a little hypotensive, borderline. So the sugars are quite low and the temperature is normal. So for this case, you have advised your staff to give 100 ml of 25% dextrose. So say your workplace doesn't have it in stock and only 5% dextrose is available as 500 ml of bottle. So instead of 25% dextrose, 100 ml, your workplace is having only 500 ml, 5% dextrose bottles only. So if you give 100 ml of 5% dextrose to the patient instead of 100 ml, 25%. Say your staff has made a mistake, instead of giving 25%, they gave 5%. So what is the percentage of intended dose that's been delivered? So you wanted to give 100 ml, 25% dextrose, but the staff has given only 5% dextrose, 100 ml. So what percent of your intended dose has been delivered? So if anyone can answer over the chat, we'll give you about 30% seconds. So without wasting time, let's go to the answer. So that's about 20% of the intended dose has been delivered to the patient. So because you need to know how to calculate your dosage in each. So if a medicine says, say 2% of lidocaine, you might have seen. So in that, what is that 2%? So when someone says 2%, that means they're saying those many grams in cent, that is 100 ml. So if they say 2%, that means 2 grams of that particular drug is there in 100 ml of that vial. So we have two things here, and one is 25%, 5%. So 25% dextrose in 100 ml. That means 25 grams of dextrose in 100 ml. Similarly, what's the next bottle we have? We have 5% dextrose. So in this 5% means 5 grams in 100 ml. So here we wanted to give 100 ml of 25% dextrose, that is 25 grams. So we wanted to give 25 grams, but we have given only 100 ml of 5% dextrose, that is 5 grams. So what is the percentage now? So instead of 25 grams, we have given only 5 grams, which is just 20% of our intended dose. So the answer, that's why, is 20%. But what if we give the entire 500 ml? So 500 ml is going to contain 5 into 5, so 25 grams. So in 100 ml, it had 5 grams. In 500 ml, it will have 25 grams. So both 25% dextrose of 100 ml and 5% dextrose of 500 ml will have equal amount of sugars. Just that we need to give the sugar at a fast rate. That's the reason we give 100 ml of 25% dextrose. So some countries do have 50% dextrose also available. So that is going to cause some venous damage if given via peripheral vessels, especially in pediatric age population. So you'll have to be a little careful when you're choosing any hypertonic fluids. So at 25% dextrose of 100 ml equals 5% dextrose of 500 ml. So most of the people, when I ask which one will have more sugar, they will think that 25% of 100 ml will have more sugar, but it's the same. So now your colleague recognizes the patient and says, hey, it's him again. So I see him every 3 to 4 days. That means the patient has been coming to your ED with repeated similar complaints. Now you start to suspect that someone is injecting this guy with insulin. So which lab test here can help along with insulin levels? So you will obviously ask for insulin levels. Maybe there is insulinoma or something. So if you are suspecting that it is being injected by someone, which other particular test do you need to do? So your options are serum electrolytes, serum C-peptide levels, and serum sugar levels. So here your sugar levels are obviously low. Even if you measure now, they're going to be low. Electrolytes may not be much relevant now, but we have to do serum C-peptide levels. Why? Because C-peptide levels will tell you whether that insulin is endogenous or being given exogenously. So let's look at this, how your insulin is made in the body. So this is the point wherein there is a cleavage. So it cleaves into C-peptide and insulin. So first is pre-proinsulin, then it becomes proinsulin. After that, it becomes insulin. So C-peptide and insulin get separated. That's how insulin is made in the body. So now, if the insulin is made inside the body, obviously it should also contain C-peptide levels of similar levels. So you will measure insulin. That is not going to tell you whether it's an outside one or inside one. So whether injected from outside or made excess in the body. So if it's made excess in the body, your C-peptide levels will also be high. But if it's given from outside, your C-peptide levels will not be high. So only insulin levels will be high. So that's how we can differentiate. So there are some causes that can cause too much of insulin secretion. So these are called as insulinomas. So clinically, these are characterized by 3 things, and we say it as Whipple's triad. So we look for 3 things. We call it as Whipple's triad. So presence of symptoms of hypoglycemia in approximately 85% of the people you see this. So the documented low blood sugar at the time of symptoms, reversal of symptoms by glucose administration. So there are symptoms of hypoglycemia. Even the sugar check reveals low sugars at the time of symptoms. And once you give sugars from outside, that is 25% dextrose, the symptoms get reversed. So these are the three things considered as Whipple's triad. So what is this? This is insulinoma is a benign tumor of pancreas. So generally, if you just resect it, it's going to be curative. So failure of endogenous insulin secretion to be suppressed by hypoglycemia is the hallmark of an insulinoma. Just a second. So failure of endogenous insulin secretion to be suppressed by hypoglycemia is the hallmark of insulinoma. So the diagnosis is done during prolonged fasting up to 72 hours when the following results are found. So serum insulin levels will be more. Normally, they should be under 6 microunits per ml, but there will be more levels. So glucose levels will be less than 40 mg per deciliter. C-peptide levels will be more. So again, insulin levels and C-peptide levels will be more. So prolonged proinsulin levels greater than 25% of immunoreactive insulin levels will also be found. So if you screen for sulfonylurea, it will be negative. So why we are screening for sulfonylureas? Because these are very prone to give hypoglycemic episodes in patients who take sulfonylureas. So that's why we want to make sure this is not causing something. So let's look at the second case. So you have a 49-year-old lady on thiazide diuretics for hypertension, with now presented with acute onset of headache, seizures, and altered sensorium. So hypertension, patient taking thiazide diuretics now has acute onset of headache, seizures, and altered sensorium. So arrival blood pressure was 140 over 100. So now you have ordered a CT. Obviously, the CT is shown as this one. So it is apparent to be SAH. So CT was ordered, which suggests SAH. So now you have treated the patient. Now you have repeated the CT the next day. So the next day CT is like this. So there is no sign of that SAH. The hints of SAH are gone. So what could have been the treatment? So this is a little tricky one. I just wanted to tell you about this case, which I've seen in the on a Twitter. So what could have been the treatment? So here, the reason for that brain appearance that is looking like SAH is severe hyponatremia. So it was the hyponatremia correction that was given. So severe hyponatremia leads to brain swelling and narrowing of subarachnoid spaces with resultant changes in attenuation of CT, giving false appearance of SAH. So if the hyponatremia is severe, it can lead to false appearance of SAH. So not just that, the pseudo SAH can also occur with severe hypoxic brain injury, cerebellar infarction, spontaneous intracranial hypertension, meningitis, etc. So you need to keep these DDs in mind when you are managing the patient with the CT that is suggestive of SAH. So here the cause was severe hyponatremia. So let's say that in the same question, that let's say that was a real SAH case, but CT looked normal. So someone comes to you with thunderclap headache and you're suspecting there is photophobia, you're highly suspicious of SAH. But you have ordered a CT and CT appears absolutely normal, but you still suspect SAH. So you wanted to do a lumbar puncture to prove that it's a SAH. So when is LP most sensitive? So that means LP is most sensitive when done at which point of time? So is it within 2 hours after 6 hours of SAH occurrence, or after 12 hours, or at 48 hours. So if anyone has an answer, they can type in the chat box. So now the answer is, it is about after 12 hours. So after 12 hours, if you do, it is going to be sensitive. So it is more sensitive if you do at 12 hours after the SAH occurrence. So this is performed to evaluate CSF for the presence of red blood cells and xanthochromia. So LP may be negative if performed less than 2 hours. So this is more sensitive 12 hours after the onset of symptoms. So we do LP to check for any RBCs or xanthochromia if the CT is negative. So if the CT itself shows SAH, you are not supposed to do LP. So let's look at some of the contraindications for LP. So LP is traditionally performed as a follow-up test when CT scan has shown no SAH. So, and you have excluded possible contraindications for the lumbar puncture, such as significant intracranial mass effect or elevated ICP, obstructive hydrocephalus, or obvious IC bleed. So when these are there, you won't be doing any CT scan. And also it should not be performed if the CT itself shows SAH, because there is a small risk of further intracranial bleeding associated with a drop in ICP. So when you do a lumbar puncture, you're relieving the pressure in the system. So once that lumbar puncture is done, if the ICP falls, that is going to cause even more bleeding when there is already an SAH. So you're not supposed to provoke it more. Now let's look at the third case here. So your resident wants to know if the dual chamber AV sequential pacemaker is working on a patient with hyperkalemia. So we can say this as dual chamber pacing because everywhere you see two pacing spikes. So two here, two here, two here, like that. You have multiple areas with pacing spikes. So two spikes are seen. That's why it's called as dual chamber pacing. Now in this patient, there is potassium of 6 millimoles per liter. So it's a hyperkalemia patient. And do you think the pacing is working? So how much capture do you see in this? Whether it's 25%, 50%, or 100%. So I'll show you the image once again. So here the pacemaker rate is set at 100, but the ventricular rate is only 50 beats per minute. So you can see there are these two are not generating any PQRS, but this one is followed by a QRS complex. So this one is followed by a QRS complex, this one is not. So you have about 50%. So pacemaker rate is about 100, ventricular rate is about 50. So pacemaker is failing to capture. So there are wide QRS complexes, ST wave abnormalities are also seen. So how do we name these pacing things? So once the patient is on pacing, so we label them as position 1, 2, 3, 4. So for example, if you have 3-digit code that says AAT, that means first position is the chamber that is getting paced, and in the second position we mention the chamber that is being sensed, and the third is what is the response after that gets sensed. So position is sensed activity. So triggered means once the activity is sensed, it is going to trigger. Inhibited means once the activity is sensed, it is going to inhibit the next paced signal. So that's how we put these things like sometimes it can be pacing both the chambers, atria and ventricles. In that case, we say dual chamber paced. Sensing also whether it can be atrial, ventricular. Zero means none. It is not sensing anything. It is going to deliver those whatever you set the rate, those many impulses it is going to deliver without sensing anything. So position 4 is ability for rate modulation. Say if someone is running, in that case you need more rate. So whether this pacemaker has that capability or not is indicated by the fourth position. 0 means none, R means rate modulation is possible. Next is it allows the indication for multiple stimulation sites within one anatomical area, whether atria or biatrial pacing like that. So for example, if the pacing says AAI, that means it is pacing the atria and sensing the atria, and it gets inhibited when there is atrial inherent activity. So if the atria is beating producing its own impulse, it is going to inhibit the pacemaker from firing another impulse. So that is AAI. Another example is VVI. Similarly, it paces the ventricle, senses the ventricle. So if there is already inherent ventricular signal, so it is not going to fire. So VVI is ventricular pacing and sensing getting inhibited with ventricular activity. Other is DDD, means it is going to sense and pace both of them. And again, it is going to do both things. It gets triggered and inhibited based on whether there is any activity within the atria and ventricles. So there is something called as magnet mode. So this varies with model. So usually it is going to stop whatever the mode you have kept in the pacemaker and changes the pacing modes to AAO or VOO or DOO. Means what was the O standing for? When it says AAO means none. So here, which delivers a constant rate regardless of native rate of rhythm. So that means it's asynchronous. It doesn't sync with your heart rate. Okay, so it is not going to sync with your heart rate. So in asynchronous ventricular pacing, there is a risk of pacemaker-induced ventricular tachycardia. So note that this differs from magnet application to ICD, that is implantable cardioverter defibrillator. In that case, it is going to result in defibrillator deactivation. So magnet is generally used to either manipulate a pacemaker or an ICD. When you put it on an ICD, it is going to stop the functioning of that ICD. Whereas if you put that on a pacemaker, it is going to change the mode into asynchronous mode. So how does it work? Say there are two leads that are connected, say battery wires or something. So when you put a magnet near to that, so it is going to pull one of the leads closer to it, creating a disconnect between them. So based on that, these things work. So this disconnect is going to cause a change in either mode or change in the way it functions. So it is not going to stop altogether. So now the patient has a pacemaker set on VOO mode and pace rate is set at 70. So now you are using a pacemaker that is set at 70 and mode is VOO. So the patient is now running with an inherent heart rate of 110 per minute. So what would be the pacer firing rate? So you have set a rate of 70, but the patient's own heart rate is 110. Now will the pacemaker fire? If it fires, what will be the rate? Or if it doesn't fire, it's going to be 0. So will it fire or not is the question. So VOO mode is also called as asynchronous mode. Means it doesn't care what the patient's heart rate is. So you have set it at 70, so it's going to fire at 70 irrespective of the patient's heart rate. So it is going to fire at 70 per minute. So these three modes, AOO, VOO and DOO modes are asynchronous. They do not care about the heart rhythm or rate. They just fire at the set rate. So in this case, it was 70. So let's look at what is capture in pacing. So electrical capture and mechanical capture are two things. So look at the ECG on the monitor. First, look whether the leads are in position. So each pacing is going to invoke a spike. So this is the spike coming from the pacemaker. So if each beat is followed by a pacing spike, so pacing spike that gets followed by a beat, that means it's a capture, electrical capture. So generally during pacing, it's safe to touch the patient. So here you can see, but these two, you don't see the QRS complex after your pacing spike. That means electrical capture is not working here. So similarly, how do you check the mechanical capture, whether it's working or not? So you will check for if there is any palpable pulse, or if the blood pressure has improved, patient's consciousness improved, the skin color and temperature of the skin are better now. So to be able to observe all these things, you should get both electrical and mechanical capture with the pacing. So now what to do? If there is a electrical failure itself, that means wherever there is a spike, you get to see a QRS complex, but the spike itself is missing. So in that case, you need to increase the amperes or check the cable connections or check how the pads are attached. So sometimes for pacing, we use the adhesive pads. So they sometimes fail to attach to the body properly. So check if there are any medicine patches underneath, check if the distance is too high between those two pads, and check the pad positioning. So maybe you haven't placed the heart in between the two pads. So that you need to check. So first step is increase the amperes, check cable connections, check your pad positioning. So what if there is mechanical capture failure? In that case also, you can go for increasing in amperes, pad positioning and patient factors. Check if there is any electrolyte abnormality, correct it. If there is an MI, you have to take care of it. And check if there is any drug that is causing all this bradycardia and all. So the capture rate with AP is much better than anterolateral. So anteroposterior, you can see 78% of capture can be achieved. In female, it's close to 100. In males, it's close to 70%. Whereas anterolateral, you can see the capture rate is much low. So the next time you try to pace someone in ER, try to go for anteroposterior pad placement. So this is going to help you achieve the pacing with much less amperes usage, and the patient will be comfortable. Otherwise, when you put it on anterolateral mode, you have to use a larger amperage. So that is going to cause discomfort to the patient, because with every pacing impulse, there is going to be twitching in the musculature of the patient. So that is going to cause discomfort even though you give some sort of sedation. So to avoid that, anteroposterior is going to help you. So choose AP. So especially in pediatric, we always go for AP. So in adults also, try to go for that. Let's look at the fourth case. So a symptomatic bradycardia patient received 600 mcg atropine in ambulance and now has reached your ED. So the heart rate is about 30 to 40, BP 121/58, capillary refill time of less than 3 seconds. The patient is oriented with a GCS of 15. Now the BP on the previous visit was 194/93 and 164/87. Now the patient has hypertension, diabetic mellitus type 2, ischemic heart disease. It's a CKD grade 3 patient. So the patient is taking bisoprolol 2.5 mg daily, aspirin 75 mg daily, dapagliflozin 10 mg daily. So these are the current medications. So this case has been taken from ASEM learning. So now the ABG is showing a potassium of 5.9 millimoles per liter. So ABG shows 5.9 millimoles per liter. So what is your next step in the management? So if you want to take a closer look at the ECG, let me zoom it for you. So what is your next step in the management? Observe and wait for the cardiac team to return. Start isoprenaline infusion. Administer a further dose of atropine up to 3 milligrams. Treat hyperkalemia. Initiate transcutaneous pacing. So in this patient, we have one of the reversible cause that is causing all this. So in this case, it is better that you take care of that causative factor. So hyperkalemia is the reason the patient is exhibiting all this. So first to try to handle that. So you treat the hyperkalemia. So if it still doesn't subside, then you can go with the rest of your bradycardia management algorithm. But first, you have to take care of the reversible causes which are causing the bradycardia. So in this case, hyperkalemia is there, so take care of it. So how do we take care of this hyperkalemia? So your first step in handling hyperkalemia will be your calcium. So calcium is available in two forms, calcium chloride and gluconate. Chloride has higher content, approximately 3 times the content compared to calcium gluconate. But most of our hospitals in India make use of calcium gluconate. Calcium chloride is a little irritant to the veins, so gluconate is better tolerated. So you can use as per what is available in your ED. And most of the times we give 10 ml of that calcium gluconate. But it is not a one-time dose. So if your patient is still exhibiting the signs relevant to ECG abnormality, till the subside, you have to give your calcium. So you're giving the calcium to stabilize your heart electrical issues. So it is not a one-time dose. There are occasions I've given 4 ampules also. So it all depends. If it's a CKD patient with high chance of hyperkalemia, you may have to give repeated doses. Till then, you will not achieve the ROSC after a cardiac arrest. So especially in cardiac arrest situations, you may have to give repeated doses if the ECG is still showing abnormalities. So now you have given potassium correction. So first step is always your calcium. Then you will start your beta 2 agonist inhalation and insulin along with glucose, and soda bicarb also is tried. So all these things are going to help with that. So potassium correction has restored sinus rhythm. So what is the mechanism of bradyarrhythmia in this patient? Why the patient had bradyarrhythmia? So coronary artery disease because of ischemia, hyperkalemia, drug-induced bradycardia, synergistic action of hyperkalemia and beta blocker, degenerative cardiac conduction system. So the answer here is D, that is synergistic action of hyperkalemia and beta blockers. So this is an interesting concept that it's called as BRASH syndrome, BRASH. So BRASH exists at the nexus of hyperkalemia and AV node blockade. So these 5 things stand for 5 different entities, that is bradycardia, renal failure, AV blockade, shock, and hyperkalemia. So when someone says BRASH, these 5 things they are meaning to tell you. So this is one of the infographic that depicts BRASH. So because of renal failure, if the patient is already on beta blocker or calcium channel blocker, it can cause bradycardia. So accumulation of renally cleared beta blockers will be there in renal failure. So beta blockers will be accumulated. So these are going to cause non-selective beta blockers cause hyperkalemia also. So hyperkalemia in turn can also cause bradycardia. So this bradycardia leads to a kind of shock state resulting in poor renal perfusion, which leads to even more renal failure. So this is like a cycle. So that's why it's like a syndrome kind of thing. You can say it's BRASH, bradycardia, renal failure, AV blockade, shock, and hyperkalemia. So this ends our session on these 4 case-based discussions. So if you have any more queries related to these, you can reach me on this, or you can just type in. Again, you might see different names for the webinar because I had to fill in because Dr. Ankur was actually supposed to speak. Unfortunately, he couldn't join us. Okay. Thank you, Sravani, for calling me in.
Thank you, sir. The cases were such very detailed, clear. I think these topics are really very important for all the ER physicians. Yeah. Thank you, sir. Thanks you once again.